She's a physician assistant, healthcare professional with over 20 years professional experience, augmented by a Master of Medical Science. Jacqueline has comprehensive knowledge of and experience in movement disorders and expertise in deep brain stimulation. She is a licensed physician assistant and executive director of the Deep Brain Stimulation Program at JFK Neuroscience Institute. Her responsibilities include preoperative patient selection, medication management, intraoperative care, and postoperative DBS programming. So she's the one who's going to program you afterwards. Jacqueline also serves an assistant professor of neuroscience at Stetson Hall University School of Health and Medical Sciences in South Orange, New Jersey. Her career objectives and passion has been to educate patients, families, students, and clinicians regarding movement disorders and the therapeutic role of deep brain stimulation in treatment of Parkinson's disease and other movement disorders. So we're so glad you're here today. Thank you, Jacqueline, for joining us.
Well, thank you for inviting me. Educating patients on deep brain stimulation, Parkinson's disease in general, it has been my passion for many, many years. I do many patient support groups and as well as peer groups, but I do truly enjoy sharing my knowledge and answering whatever questions that I can. And if I don't know, I'm not afraid to say I don't know. I'll try to find out, but I don't know. So everything you ever wanted to know, I don't know. As I said to Eden, none of us knows everything, and I'm always learning. Just as when you think you know it all, then you got to start from scratch. So I'm very pleased to and honor that I've been invited as a speaker, and I hope the slides come through. We've had some technical difficulties as usual on online. There we go. Okay, can everyone see that? Are we all?
We are good to go. Thank you.
Oh,
but I love
terrific. Yep. Okay, so as Eden said, yeah, I'm a physician assistant. Actually, it's now our title is physician associates. It was adopted last year by AAPA, although it hasn't been. It's not widely known, unfortunately, but I'm very happy about it. I was on the committee, voted for it, because I think it better really acknowledges that when we don't assist, but we are, most of us work, when we've done this for many years, we're pretty independent. So it's really a physician associate. So I am the deep brain stimulation specialist at the Parkinson's Disease and Movement Disorder Center at RWJ Barnabas Health, and I've taken the liberty of using the acronym DBS for "Don't Be Scared," because I know when patients initially hear about it, their first reaction is, no, not for me. That's brain surgery. And that's certainly a reaction that is typical and warranted, and it takes some, education to understand that it's really not as bad as it sounds. Can I move the slides, Kelly, or do you? Oh, okay. So I'm just going to briefly talk regarding Parkinson's disease. I assume everybody here has got Parkinson's disease. So it is the second most common neurodegenerative disorder. Alzheimer's is number one, Parkinson's disease is number two. And they're metabolically, or at the molecular level, I should say, are very, very similar. They really deal are affected by the same proteins in the brain. It affects 1% of the population over 65. 10% are young onset, diagnosed prior to the age of 40. And that's 40 to 50, really. And we're seeing more and more younger patients simply because there's a heightened awareness now of Parkinson's disease. As you know, 500,000 people diagnosed with PD in the US, and that is predicted to triple over the next 50 years, which is not surprising. And it is slightly more common in men. Sorry, guys. Next. So it remains a clinical diagnosis. It's based on signs and symptoms. We do have a DAT scan, which is the only FDA-approved visual adjunct imaging that we have in adults that you're not quite sure, is it Parkinson's? Because sometimes it's not always very clear. If patients come in with what we call atypical or uncommon symptoms of Parkinson's disease, we may want to get a DAT scan. If they have a tremor, but no other cardinal symptoms, such as slowness or stiffness, is it essential tremor? Sometimes you really don't know. And many, many times, many instances, many years before you're diagnosed with Parkinson's disease, I've had many patients that were treated for essential tremor years before they were finally manifested other symptoms of Parkinson's disease. So it's not that uncommon. And the DAT scan can help differentiate. If it comes back positive, it doesn't tell you anything about progression of disease. And most movement disorder specialists don't really need to confirm the diagnosis with a DAT scan. Because we see patients all day, every day. So we can pretty much recognize the clinical signs and symptoms. But if you're not sure, or if patients need to see something more confirmatory, because, it's, especially in young patients, it's denial is very, very common. No, it can't be, so they'll get maybe second and third opinions. And finally, a DAT scan will convince them that, okay, I do have Parkinson's disease. And from there, they can move on with dealing with it. Okay, next. So what or who is the culprit? So substantia nigra, that's a little part of the brain that has the dopamine neurons in it. And it's, as you can see on the left, that's a normal substantia nigra. And on the right, that is a patient with Parkinson's disease. And you can see where that dark area is much smaller in a patient with Parkinson's disease. And that represents, for all practical purposes, that represents the dopamine or dopaminergic neurons that are being lost. And that is it is a progressive disorder. If it's idiopathic, the most common form of Parkinson's disease, it progresses very slowly. If it is a more atypical form of Parkinson's disease, the progression is much quicker. And those patients are not candidates for deep brain stimulation. Idiopathic is the only indication in Parkinson's disease. Next. So this is just I'm sure you've seen this slide before, but it's always good to review the 3 cardinal symptoms. That has not changed since the essay written by John Parkinson's. Tremor, bradykinesia, which bradykinesia, a medical term for slowness, and rigidity or stiffness, as you would describe it. So those are the most 3 cardinal motor symptoms. But there are many, many non-motor symptoms, and many of those can show up years before you see a motor symptom. Sleep disturbance or vivid dreams is very, very common non-motor symptom. Your sense of smell diminishes, anxiety, depression. But when you're thinking about these symptoms, many of them do not lend themselves to a diagnosis of Parkinson's disease, which is why when patients are diagnosed, and I could tell you that in my clinic, they may have had symptom diagnosis. It's just nobody's put the pieces of the puzzle together to come up with and say, okay, it's time for you to go see a Parkinson's specialist or a motor. Unfortunately, most patients don't know what they associate movement disorder. They don't realize, well, Parkinson's disease is actually a movement disorder. Next. Oh, okay. I thought we froze again. Oh my God. So in medication wise, levodopa, since the 60s, we haven't come up with anything better pharmacologically. It is still the mainstay of Parkinson's therapy. And typically, if it is the most common form, idiopathic, there is a robust response. Now, I don't know any of your experiences, of course, but I've had many instances where patients have been referred or come in and they were given a prescription for Sinemet or carbidopa-levodopa and told by the prescriber or the provider, well, if you're better, if you feel better, well, you have Parkinson's disease. And that is really a pretty cold way of presenting a life-altering diagnosis to a patient. Yeah, you take this, if you get better, you got Parkinson's disease. And it's it's really not uncommon to hear that from patients that are not seeing movement disorder specialists. It's a horrible way to be told and to find out and then to have to deal with it. So motor complications do emerge over time when you're taking medications, which, leading into deep brain stimulation, it's probably the most common reason that patients do finally decide that deep brain stimulation is for them. Next. I always like this slide. It's been around for a long time. But what I like about this slide is that it shows you early on how the Parkinson's disease progresses. Initially, patients have a nice threshold response to medication. They haven't gotten form of dosing Sinemet, depending on the patient, of course, but one tab 3 times a day. And that pretty much is the most common prescribing for Sinemet initially. And that doesn't last too long because eventually you move into, after a couple of years, you're reaching that dyskinesia threshold. Why are you getting up there? Because we have to increase the medication or shorten the time between medication dosing, because Sinemet, as good as it works, because all it's doing is replacing levodopa, which dopamine, which is, you're getting levodopa, which is it turns into dopamine in the brain. So that gets shorter and shorter. Your on time becomes shorter. Your off time becomes longer. And then in advanced PD, of course, you have very, very short on time and very, very long off time. So patients, you don't want to get here for before you make a decision for a deep brain stimulation. You want to be somewhere here, because when you're in advanced, stages and you're no longer responding to medication, or you're no longer responding to dopamine, it's a pretty good indication that you're not going to respond to deep brain stimulation. So it's a shame. The reason why I'm so passionate about educating patients on this therapy is that many do miss that window of opportunity. And it's a pretty big window, but when it closes, you're stuck. So appropriate candidates. I'm asked this question all the time. As I said, idiopathic Parkinson's disease, and 85% of patients that are diagnosed with Parkinson's disease, thankfully, are idiopathic. So they respond well to medications, or they respond well to DBS. Essential tremor, it's really a no-brainer. It's almost become now the standard treatment in treating essential tremor. And dystonia responds very, very well. It's the only treatment actually for dystonia. So it's not new. This is a very old graphic, and it's been around for a long time. 25 years, we're now really around 30 years. And it has become the standard of care for patients with treatment refractory motor circuits disorder, such as Parkinson's disease. It's highly effective at controlling motor symptoms. And what is the actual procedure? It's done, well, it depends on the center, the neurosurgeon that you're going to, that you work with at my sin. I've never, in all of, what do you hear? Did we freeze?
Freeze. Can you just go back a little bit and just explain?
Yes.
You did talk about how it's been 25 years. It's not new.
Oh, okay. Yes, it's actually been longer than 25 years. So but the procedure has not changed in all of those. It's gotten better, but the actual implanting of the electrodes and the generator, stage 1 is implanting the electrodes in a very deep part of the brain. Depending on which center you're with, which neurosurgeon's doing the surgery, it can be asleep or awake. We do all of ours awake unless it's dystonia. Then patients don't need to be awake. But for Parkinson's disease, particularly tremor dominant, we do it awake because we want to be monitoring your symptoms. And we use a frameless procedure. So it's implanted in the brain. And once they're there, they're there. I have not, in 20 years of treating patients, have ever seen an electrode move, be dislodged, because they're pretty deep in the brain. And then that's the second stage. A week later, you get your generator or battery, which is very similar to a cardiac pacemaker. A lot of people just come in to the clinic and your system is turned on, and we start finding the best area to stimulate. Did you lose me again? We okay?
Yeah, we did. We're good.
Okay. So yeah, the window of opportunity: on time with disabling dyskinesia or other non-motor side effects, off time characterized by disabling tremor, rigidity, or bradykinesia. And tremor responds extremely well to deep brain stimulation. All of the symptoms do, but tremor is one of the symptoms that is so much more refractory to medication, regardless of how much you use. And you get to a point where you really more is not better because it's not making the tremor better. And you may be crossing that threshold into dyskinesia or even other side effects. Or what a lot of patients have on and off, unpredictable on and off motor fluctuations. They're not sure when the medication's kicking in. They're not sure when it's going off. So they can just go off when they don't even realize it. And all of a sudden they're off, sudden offs, very disconcerting. And medication-resistant tremor, and most tremors are medication-resistant. Next. So, keys to success. Patient selection, you have got to have the appropriate indication for deep brain stimulation. If it's Parkinson's disease that is not idiopathic, then you are not, at least in my center, and I'm the gatekeeper. I work with a wonderful neurosurgeon who he does not make it should be like that everywhere, but I'm not sure it is. So it's got to be the right patient with the right symptoms that respond to dopamine. If you are not responding to dopamine, if your symptoms don't respond to dopamine, you're not a candidate. It's as simple as that. The first step in my criteria for patient selection is a dopamine challenge. Patients have to come into the office off medication for, I like a minimum of 12 hours. And we go through the motor exam and score that off. They then take their medications and we wait till the medications kick in or they feel on. And we repeat that. And if there is a 30% improvement in motor symptoms on medications, then that's a rule of thumb. Okay, we can move to the next step. Honestly, I see usually a much higher percentage of improvement. I rarely see anything that low. But that's kind of that was established by somebody somewhere, so who knows? So everybody goes by it. But that's the first step. And if you do continue to have a good response to medications, if you have gait freezing and balance issues and that doesn't get any better with your medication, well, it's not going to get any better with DBS. You have to have realistic expectations, what the surgery will do for you and what it won't. I mean, sometimes we're surprised because it helps things that we're not expecting. I've had almost all my patients sleep much better. I don't know how many studies have been done on that, but it's anecdotally, they sleep much better. So you must have a good neurosurgeon that is very experienced in doing this, and that gets the electrodes, the contacts precisely where they need to be in the brain. If that is not, if the electrode is off by a couple of millimeters, you're not going to get a good response. So that has gotten so much better over the years. The technology has just, in the past 5 years, the technology has exploded. Things we saw 5 years ago, 10 years, we don't see today. We can work around. And then last, you have to have someone who is experienced in not only programming, but in adjusting your medications, because they work synergistically. The whole purpose for patients most of the time of making the decision to move forward is so that it's the quality of life. They don't want to be thinking about, they have to take the next dose 3 hours. they're going to be off. So once we turn the stimulation on, we give it a little bit of time, and then we start adjusting medications. The goal is not to get patients off medications. I know a lot of people may have that misconception. The goal is to improve your quality of life, and we get you down on the lowest dose of medication that you can function well with. And many, many times, that's all you need. You avoid the side effects, the dyskinesia, hallucinations, all of that. Once you're down at to a dose that is going to work well with your stimulation, because you're never off anymore. Once you have DBS, you're on 24/7. You never have those deep valleys anymore. It's a much smoother ride throughout the day. And the most common refrain I hear from patients is, I should have done it sooner. Seriously. Next. So there's a great study. It's called Early Stim Study. Earlier is better, absolutely. And this goes back many years. There have been many studies. Quality of life compared to best medication therapy, less anti-PD medication complications, such as I mentioned earlier, improved social and occupational activities. So this is STN, which is the subthalamic nucleus. There are a couple of sites that we use in the brain. That's called a target. And the subthalamic nucleus is usually where, for most Parkinson's patients, that's where the neurosurgeon will place the electrode in a specific part of the subthalamic nucleus, which is about the size of an almond. So you can imagine the precision it takes to get an electrode precisely at a certain point in that almond, in your brain. So you've got to be working with somebody that's really passionate about what they're doing. And I'm so blessed that I work with such a great neurosurgeon, and we have such a wonderful team, because not only am I in the OR with the patients, but following, once they get to clinic and they get programmed, he just wants to know how they're doing. So I've got lots of pictures of me and patients with smiling faces. But that's the most common target in the brain that we use, is the subthalamic nucleus. Next. Candidate selection. I think I alluded to this a little earlier. Dopamine challenge. Then a neuropsychological evaluation is necessary. We want to make sure there aren't any red flags like dementia, psychosis, and we revisit that 6 months to a year after surgery to see what's changed. An MRI of the brain, of course, DBS protocol, that's really for targeting precision by the neurosurgeon. We refer them to the neurosurgery, and then we have a monthly case conference and discuss what's the appropriate brain target for this patient. And that can vary. Next. So benefits, I think the other slide showed you. This is a little bit more simplistic, but you see the ride is much smoother throughout the day. It's not like being on, I don't know, those crazy roller coasters they have now in the theme parks. Now you're on a nice little baby roller coaster instead of one of those that you go down very fast. So that's really is what we typically see after surgery. Next. Okay, so just for your own information, the electrodes in all of the systems now, and we have 3. We have Medtronic, which was the first for many years. Abbott, which came out with the first directional, and then Boston Scientific, and they all have what we call directional leads. These contacts, each electrode has 4 contacts, and ideally you want to get contact 2, contact 3, or the directional contacts right into that really sweet spot in the subthalamic nucleus. You want, well, wherever you're going, you want to get these because these give you the most flexibility in programming. You can steer away from areas that might cause side effects and steer to the areas that are going to give you the optimal benefit. So that's why precision, optimally placed electrodes, a neurosurgeon, that's good. Very important. So that's typically, I mean, they're about the size of angel hair pasta, if I can make that analogy. That's about how big the electrode is that's going into the brain. Very, very small, tiny wire. And these are 1 millimeter. These are a millimeter. So you could imagine there's only a 0.5 millimeter space between these. How small an area we're dealing with that can make an incredible difference in the lives of people. The brain is, there's not a lot of real estate there. So you have to know where you're going. Location, location, location. Next. So I just wanted to show you through the graphics of the different systems. This is the Boston Scientific System. They have 3 types of batteries. One is rechargeable. One is primary. Most patients go for a primary cell, which means that you don't recharge it. The patient has no responsibility to recharge it. And today, with the technology where it is, you're getting at least, I would say, 5 years out of a battery. And changing a battery, for those of you who aren't familiar with it, it's a very simple outpatient procedure. Has really nowhere as traumatic as putting electrodes in your brain. That's never touched again. It's like scientific offers for programming is image guided programming. Am I still there? Okay. So, and every patient gets a personal programmer, which allows them to, if we have 3 or 4 programs in there for different reasons, patients can move from one program to another, or they can increase their stimulation or decrease their stimulation. They can put it in MRI mode if they're going for an MRI, surgery mode. And those are things that are available in all of the system. And this is the charger. If a patient does get a rechargeable, they charge their batteries, usually on a weekly basis, an hour a week. And those last 15 years. So depending on what the patient wants, we give them what they want. Next. And this is the Abbott system. So Abbott was the first directional lead, which was truly a breakthrough in DBS. And patients can download an app on their phone. And now, as of March 1st, I'm told they're giving out iPhones to every patient so that they can have the app on their phone as opposed to an iPod, which is what they used to give them, or they still give them. And I think what Abbott has also is the thing that's appealing to some patients is the virtual programming option. So you can be at home if you can't get to the office. It really is very convenient for patients that either do not drive, someone has to drive them, live a distance away, or travel during the winter. Snowbirds, they go down to Tampa and they can access us for programming. So I think it's a again, choice of the system depends on your lifestyle and what you need. Abbott does not have a rechargeable battery. But honestly, they all do the same thing. Next. And this is Medtronic. So Medtronic, we use Medtronic. That was the only system available for 20 years or more. So again, they have very, very good technology programming. They have it's called a brain sense technology, where the patient has the ability with their programmer to put in their symptoms when they're occurring, when they take their medication. All they do is tap on their programmer. Okay, so took my medications at 8 o'clock. I had a tremor at 11. I became dyskinetic at 12, went off at 1. And that information is all recorded, and it's brain sense. They're actually reading certain brain waves in the brain. And when the patient comes in, I'm able to look at that without them telling me if they've, you know, been pretty, I guess, responsible to do that. I don't need to worry about getting the history from them. It's all there on my programmer. So they have sensing, directionality, visual programming, and again, their electrodes, that's the sensing enabled directional leads. So again, we can have, without having to guess where we're going to program, the more helpful it is for us and for the patient. It just makes life a lot easier. So those are the three systems. Next. So again, it's just, what is it? Again, it's there's a graphic view. There's the actual electrodes implanted, as you can see, very deep part of the brain. And it's just implantation of an electrode. And how does it work? We don't know. We just know it does. It's stimulating and changing
She froze again, but I did like that. Sorry, go on.
What, dear?
We only got to the part where you said that nobody really knows how it works. We just know that it does.
Oh, yeah. You know, there's many, many theories. I mean, it says they've been using it for, I mean, years and years before it ever got FDA approved. We know that it changes the electrical circuitry in the motor area of the brain. And it does what stimulates the neurons as taking medication would do. But you don't have to take medication to do it. It's now done really through electrical stimulation, but you don't feel it. Next, so there's just a timeline. It was first approved for tremor in 97, for PD in 2002, and for dystonia for 2003. So it's not a new therapy or a last resort. And I do want to get that. If there's anything you take away from this, just know that it is not a last resort. And if you ever hear from someone, if anyone ever says, well, you know, there's not much I can do, the medication's not working, maybe you should go see somebody about DBS. Don't wait for that, honestly. Because if medications aren't helping you, you're in an advanced stage and DBS isn't going to help you. And I would never send someone on for surgery if I didn't think it was going to be beneficial for them. So that's my takeaway message. Next. Okay. It's effective long-term. Once those electrodes are in, they're in. And again, the efficacy and safety depend on the spatial restriction of the stimulation. Side effects emerge if the volume of, which we don't really see anymore, if the volume, because we're not activating. Now we have the ability to avoid areas that might, that we don't want to activate. That all came about with the directionality, the directional leads. And that was, you know, that was really a game changer for many of us in programming, because we could focus the stimulation where we needed it and and really remove it from where it was causing a side effect. So that's really, we don't see a lot of that anymore. As long as we have good placement, good neurosurgeon, good program. Next. This is just a little slide I have on the difference in the tremors of, that's a Parkinson's tremor, which is on the top. That's a tremor at rest is what describes a Parkinson's tremor. And you can see the difference in the tremor on the bottom. That's an essential tremor, which is much worse with activation. Parkinson's tremor is more pronounced when the patient is just at rest. That's why it's called tremor at rest. And next. Well, that's just a slide on essential tremor, and I don't think anybody here has essential tremor. So yeah, I mean, the difference is when the main difference clinically anyway, when essential tremor usually is bilateral. Parkinson's disease symptoms almost always start on one side of the body and eventually progress to the other. And the tremor is usually starts on one side of the body and you gradually will progress to the other. Essential tremor, the tremor starts almost always in both hands or head or voice, but it's bilateral. All right, next, I think that's the last one. Okay, I hope that wasn't too much to take in.
Excellent. So I had told you beforehand, because we always get asked this, and you had actually answered it when you were speaking with us previously. How do you decide which to use? Boston Scientific, Medtronic, and Abbott, you talked about how it really did depend on the patient. Could you kind of just elaborate a little bit more?
Okay, so as I said, I think Abbott is an excellent choice for patients that really need more of a virtual option. If they want a rechargeable, they wouldn't go to Abbott. But not many patients do want rechargeable batteries because they just don't want that responsibility of recharging it once a week. But if they have any difficulty traveling, or if they travel a lot and they just want to be able to be in touch, if they need an adjustment or something happens and they don't want to, and they're unable to get to somebody that knows DBS or a movement disorder specialist, I think it's an excellent choice. Boston Scientific, which I think is, again, I use all of them, which I'm very happy about because I'm glad to be able to offer patients all three options. The Boston Scientific has its image guided programming, which is I find is extremely helpful. They're able to download the actual images of the patient's brain into the programmer so that I can take a look and see exactly where the electrode is. I can show it to the patient and they're just kind of blown away. Is that my brain? Yeah, that's your brain. And that's your STN. And that's exactly where that electrode is. So again, it's one of those elements that takes a lot of the guesswork out of programming. None of them are 100% accurate. You just don't know. You're in the OR, you think you're exactly where you want to be, but maybe it's not exactly where you want to be when you get into clinic. So you have to kind of work around that. And the imaging really helps tremendously. So that's, Boston Scientific has absolutely great technology. Medtronic, I have found very useful in the using their brain sense data, and Boston Scientific, they partner with it's called Brain Lab, which gives us the imaging. And Medtronic has a brain sensing, which again, it's another form of just improving how we get to where we want to be in programming without a lot of guesswork. I don't want to pick one over the other because I don't want to appear biased, honestly. But when patients, I educate patients on all systems, and I, ask them to contact the local reps or the websites who will then give them a lot more information. So Medtronic is now there's an app, and I'm not sure how many patients are aware of this app. And I don't know if you've heard of it. It's called Strive PD. Yes, okay. So now Boston, Medtronic, and it's a really good app. So you don't have to have Medtronic to get this app, but Medtronic, with the Medtronic system, they're giving patients an iWatch. Okay, so that you can record what's going on with your symptoms. You wear the iWatch, to bed, and you'll know how many hours of sleep. Did you have symptoms during sleep? And that data, when I'm connected to that, and if it's done through Medtronic, I'm connected to that, I can actually read that data. So I know precisely what's going on with that patient for the 2 weeks or a month that I've seen them last. How many hours of sleep they got, how much tremor they had, dyskinesia. So it's a really nice app to have, and any patient that has a smartphone can download the app.
We did get a question about, could you comment on adaptive closed loop DBS?
Not really, because we're not even there yet. So I want to deal with what we have right now.
Someone asked if dyskinesia could be induced by DBS.
Yes, it can, but it also. So here's the skinny on that. So if I'm programming a patient and they become dyskinetic, electrode is precisely where we want it to be. Did you lose me again?
No, we got you.
Oh, okay. So what that tells me is that electrode is and how do we, because if you're becoming dyskinetic, we're stimulating an area that's causing you to become dyskinetic. So that's not a bad thing. And we can certainly adjust that. So yes, can it cause dyskinesia? Yes. If I see dyskinesia, doesn't worry me at all. Because it's just a matter of programming and dialing down medications for the dyskinesia to subside.
We have a question about.
Oh, I didn't hear.
If the issues are with PD are largely memory and other mental issues, not so much the motor issues, she was told DBS is not effective for non-motor issues. Is that the prevailing thought?
It really is more for motor symptoms. When you're talking about non-motor, it honestly depends on specific non-motor symptoms, that you're talking about. Sleep is a non-motor symptom. Anxiety and depression are non-motor symptoms. So it's really a mixed bag. That's why we do the neuropsychological evaluation. Is it going to, are you going to feel better afterwards? Well, for the most part, yes, because you're now able to live a better quality of life. So it does improve depression, but it depends on what symptoms you had prior to surgery. That's why all of the pre-testing is so important. If there's dementia, no. If there's really cognitive a history of psychosis, it's a red flag. But is it going to improve mood? A lot of times it does, because patients are happier. I can't tell you how many patients I have over the last 20 years that tell me it's given me a new lease on life. So yeah, I've had wives say, "What'd you do to him? He's happy now." I said, "Well, do you want me to make him sad? What do you want me to do?" That's a good thing. So it depends on I really can't answer it, easily.
Questions about the surgery itself.
Mhm.
As far as, could you describe the actual procedure? Does the patient get a local anesthetic? Are both sides done simultaneously? What does that look like? The actual procedure for DBS.
Well, again, that neurosurgeon, I'm sorry, dear. It depends on the center that you're going to. As I said, I was in Austin over the weekend at a DBS conference, and some of them do it in 4 different stages. They'll do 1 electrode, then the patient will come back and get a battery. 6 months down the road, they'll do the other side, and the patient will come back and get a battery, and it's 4 different procedures. Some institutions do 1/2, and then 6 months later, they'll do the other. Where I am, and this has been my experience since I've been doing this, is that we do 2 stages. The first stage, yes, ideally the patient is awake. Do they get any anesthetic? Well, of course they get some local anesthetic for the burr holes, because you got to get into the brain. And we don't want patients awake while they're getting burr holes drilled in their head. But it's a short-acting anesthetic, which is good, because general anesthesia and Parkinson's disease don't mix well. So that's a local. Patients are awake. Depending on whether they're doing one side or both sides, and how skilled the neurosurgeon is. We do both sides of the brain at the same time in Parkinson's disease. We don't do one side because it's a bilateral disease. And then a week later, the patient comes back for a battery placement. For that, the patient is under general anesthesia, but it's not a very long procedure. The battery is implanted usually in the right side of the chest. You don't see anything. It goes into the muscle because you don't want
Jacqueline froze again. Not just physically, because she is cold in Pennsylvania. We are going to ask a few more questions. I do know from previous, somebody said after DBS, one can jog and bike, swim, do all that good stuff. So it doesn't really change your lifestyle. Somebody had asked about the orthostatic hypotension, and I actually reached out to our APP Kelly, because they put NOH and I wasn't 100% sure what that meant. So she did answer that question, that it was neurogenic orthostatic hypotension. It can help secondarily by means of reducing medication, which can contribute or worsen your orthostatic hypotension. But DBS does not reduce the underlying disease process that may contribute. The question was about, whether or not that would help with those medications to lower them, the DBS. So you don't have to, you can take less of your medications, which if they're lowering your blood pressure will help.
Yeah, so interestingly, what I have uncovered, and I'm actually working on a paper for this, is, the Parkinson's medications lower blood pressure. Most patients develop hypotension from Parkinson's disease itself, but also the medications to treat the symptoms. So it's multifactorial, but patients are hypotensive for the most part. Following DBS, we start lowering medications. And particularly if you're on a dopamine agonist. So that's one of the biggest culprits for dropping blood pressure. Things like Requip, Mirapex, Nupro, that class of medications drops the blood pressure all the time. So when we start lowering medications after stimulation, patients develop hypertension. So what the disease, what the medications were doing all those years is actually masking or controlling their blood pressure. So I have had many patients that have developed hypertension once we started lowering the blood pressure medications, the Parkinson's medications, and now they're on antihypertensives, where before they were hypotensive. So yes, it has an absolutely huge effect on blood pressure and sleep. Most patients following surgery, and this is strictly, no, I can't say it's strictly anecdotal. There are papers out on it. Sleep improves. Sleep improves for many reasons, but the main reason sleep improves is patients are more relaxed. They're not getting symptoms during the night, such as dystonia, which is one of the very common symptoms at bedtime, cramping of their muscles, having to get out of bed, just a restlessness. So I cannot tell you how many of my patients following surgery tell me that they're sleeping so much better. So, but we don't tell them that. We don't, that's not an indication.
You have time for a couple more questions because I know we're a little over, but somebody did ask, which I thought was good, is that obviously there are a lot of benefits to DBS, but are there any problems it creates that people need to be aware of?
Well, that really is the only issues could possibly be related to, and I'm fortunate I haven't seen very much of this. If there's something, an infection develops after surgery, if there are lead fractures, which is pretty rare. Not really, I honestly have to say. Other than related to the actual neurosurgical procedure, patients do, I mean, they do well. There's no problems you're going to see down the road that are going to be any worse than problems you would encounter if you were on high doses of medication. So no, I other than being related to the medical device itself, which is very rare, as I said, as long as you're with a good neurosurgeon who has a very good infection rate and gets good outcomes, no.
Last question is, so you've had the surgery, everything is going well, but now you're going through programming. How do you know if the programmer's doing well? Like, how do you know that the programmer's kind of monitoring your symptoms? Because it's kind of like, until it really gets figured out, you might not do as well as you could be doing. And someone was wondering, well, how does the programmer tie into that? How do I know I'm getting somebody who really knows what he or she is doing to program?
You ask, how many years have you been doing this? How many patients have you programmed? What's your experience? I mean, honestly, the biggest challenge for me as a programmer, and how do I know? Well, initially after surgery, when I turn the system on and I start programming, this is my own protocol. Patients are given right when their surgery is done, the first stage, they're given 2-week intervals to come in for visits. Once the system is turned on, I see them every 2 weeks until we optimize stimulation and medication. And sometimes it takes longer than that. So usually the first 5 or 6 visits are every 2 weeks. And sometimes we don't need all that time. Sometimes we do. It depends on how much medication the patient is on, how much adjustment we need to make. Do I drop medications as soon as I turn on stim? Absolutely not. You've got to do, at least in my experience, you have to do this very slowly. I have a patient just recently, I've known her for many, many years. She's had Parkinson's disease for over 30 years on maximum doses of medication, especially a dopamine agonist. And she is having a very difficult, she's doing great. I mean, she's symptom-free, basically, and she's on an extremely low dose of the medications now, but she has to adjust to that. The brain gets so programmed into getting all of this dopamine in this pulsatile fashion for 30 years. Well, you're not going to get over that in a month. You know, it's got to be a slow, progressive, synchronous journey between medications and stimulation. So if you're not getting the results that you expected, then I would say maybe your expectations need to be readjusted. You have to have realistic expectations. Whatever your medication had helped in the past, your stimulation will help. If you have freezing of gait, for instance, and falling and balance issues, and that does not respond to dopamine when you're taking medication, well, there's a pretty good chance the stimulation isn't going to help, but we don't know that. Gait is one of those issues that maybe it will and maybe it won't, but most patients don't. I wouldn't send a patient for surgery if that was their main problem. But you have to manage expectations, and you have to have realistic expectations. And I think some patients are not given realistic expectations, and that's what creates some problems in the end. Oh, this is not working the way I thought it was going to work. So you got to be patient, and you have to be with someone that really makes you feel comfortable and you're confident. You've got to be confident in your provider.
This was so educational. I got so much out of this.
Oh, good.
Yeah, this was excellent. Before we go, we did put some things in the chat. So if people would like to save their chat, on the bottom, there's the 3 little dots that you can use to save your chat. As always, we have a tradition here at PMD Alliance, our wave of gratitude. We're so grateful to you for giving us your time today and sharing your expertise with us, Jacqueline. Thank you so much.
It was a pleasure, and I thank you for inviting me. And I do hope that everybody gains something from it. I'm not thinking that everybody's going to run to their movement disorder specialist and say, I want DBS. But, you know, you need to, I just am so passionate about patients understanding the process. And it's such a wonderful intervention that can really improve quality of life. And I mean, that's what we're all about. That's why I do what I do. And I do hope you all got something out of this.